Hello, greetings. Amur, how are you doing?
Fine, thank you. How are you? How are you, Mr. John?
Haven't seen you in a while.
I have been busy.
Okay, of course. That's a word that's common with all neurosurgeons. Busy. You know, students say to me, "I'm busy." I say, "Where do you start your residency?" Then you'll know what busy is.
I have some problems here.
You're in what? Where are you now again?
I am in Ukraine.
Oh, okay, in Kiev.
No, Liman, Donetsk region.
Oh, okay. Okay, I'm just going to do some things, but we start in about 25 minutes, okay?
Okay.
Okay.
Hello. Hi.
Hello, JKBC. How are you?
Fine, fine, John. How are you?
Very good.
Good to see you.
Yeah, it's good to see you.
Yeah.
Yeah, we are developing this platform and learning how to promote. But the best way that I found so far is Facebook. So,
Yep.
and I think that when you have an event like this, maybe the day before, the week before and the day before.
Yep.
But the key is, like I said, in the is getting people with lots of Facebook followers like you
Yep.
that repost it on their Facebook account, because it goes out to all their followers,
Yeah. Yeah. Yeah.
And if we can get a team actually of like 20 neurosurgeons that have big Facebook accounts,
Yeah.
and they give it to all their followers,
Yep.
that's a
Yeah.
lot. It's a lot of people that see it.
I agree with you. Yeah. So this time we have done. I posted it mine, and I think many of our friends have reposted and shared the post.
Good,
Yeah.
good. That's great. Now, anyone's welcome to come in. All they do is click on the link that I have on the Facebook. The same link that you spread around is the link to come in, like you did.
Okay. Yeah.
But
Good.
some people are shy. Well, it's a new technology, so it's well, not to me, but I mean, to someone else, it's kind of daunting.
Yeah.
The first time, and you don't want to look foolish, like you don't know what you're doing. But you know how doctors are. They want to have things perfect, and some doctors want to have everything perfect. And,
I understand. Yeah, I understand.
sometimes you just need to jump in, and try something different. So,
Correct.
okay, IP, are you going to present first, or is IP going to present first, or?
Yeah, I'm going to present first. I'm not very sure, but are we going to wait for some more time, because we expecting more participants to come in?
Okay. Yeah, IP is here. He'll be back in a few minutes.
For sure. Yeah.
So, okay, I'll be back too. I'm going to do some last minute promotion.
Sure. Yeah.
Yeah. Right now it's what time is it now? 15 minutes we start.
Yeah.
Okay.
We have 15 minutes time. Yes.
Yep. Okay, I'll be back.
Sure.
Okay. Hello, Abraham.
Hello, Dr. John. Hello, everyone.
How you been?
Oh, pretty good.
JK, this is Abraham. He's a med student from Germany.
How's Dr. Parthiban?
Yeah, very fine. Good to see you. Yeah, nice.
Thank you, sir. Good to see you too.
Dr. Parthiban, do you want to go over the screen share, or you pretty well understand it?
Yeah, I can.
Okay, you can test it if you want.
I will.
I saw you toying with it before.
This is my. I open. Are you able to see?
Not yet.
Yeah.
No, not yet.
Not yet?
You got to click the share button, I think.
Yeah, I'll do that. Let me see.
Okay.
I've done that. Yeah. But it's not coming over here. On.
There it is. Coming now. It's coming now. There it is. Okay, take us where you want to take us.
Yeah.
Yep, there it is. Okay.
You're seeing my.
Yeah. Open it up. Open it up. The first slide. Okay, that's good. That's good. You got
That's
it. That's fine. And to get off it, you click at the very top. There's a says stop screen sharing.
Yeah.
Let me do that to introduce you first, so that people see your face and everything.
Sure.
Okay, can you get off the screen share?
Should I stop it?
Yeah, get off the screen share, and then I'll introduce you, and then you can go to your PowerPoint.
I'm not able to.
Okay, if you feel more comfortable there, that's fine. That's fine.
It's fine. Yeah.
Yeah, that's fine. But well, actually, can you get off it? Because I'm going to introduce all the panelists.
Okay,
right. I like their picture. You know what I mean? The big picture, so they can see your your whole face.
It's okay. Now it's okay.
Yes. Now it's good. Okay. So you're going to present now, right?
Yep.
Okay. Let me get ready to start. Let's see. You're going first before IPE, right?
Yeah.
Okay, very good. You want to wait a few minutes? You want to start?
Yeah, yeah, that's okay. I can wait for.
Yeah,
maybe...
let's wait about 5 minutes, okay?
Yeah, sure. Yeah.
It gets, I think, some people coming late.
Yeah.
As you know, that happens in medicine. I really miss the world of conferences. I didn't realize. I mean, when you train,
yeah,
it's fun. you know how it was. Everything was new, and
yes,
all these conferences and stuff. I kind of miss that.
Yeah, now it's good. Now it's better. I think some more time. I think more people will get in, and people are getting used to the webinars now.
Yeah, well, you're welcome. If you have any ideas, or you want to do a presentation on something, or you want to televise an event, just let me know.
Oh, sure. Yeah, sure. Definitely, we'll do that.
Okay. I think you'll find yourself getting more comfortable with the platform. And I think once people use it a time or two, then it's okay.
Yeah. Yeah, we are getting people now joining, more and more people joining now.
Well, there's a lot of people watching on the internet, because right now we're live on YouTube.
All right, okay.
But we haven't started recording the formal presentation. Okay. I need to click a button here that records it in good quality. And then after we're done today, I'll send it to the editor, and he'll put a little introduction, and then put the poster that we made, so we can identify who's talking, and then put it on YouTube and various other places. Hello, Axel.
Yeah.
It's good to see some new people here. Khalif's here.
Yeah.
There's Khalid. Look at that background.
That's from the WFNS symposium in Beijing.
Yeah.
Do you know Khalif, Dr. Parthaban?
Yeah. I think
Yeah,
I
we
met
met
him.
in Beijing.
Yeah, in Beijing. Yeah.
Oh, okay. Very good. Very
We
good.
met.
He's fashioning the background there. He's got the whole auditorium. I don't know how you got your face is fine. And
Yeah.
that's the background there.
How did
Yeah.
you do that? How did you do that?
Yeah.
John told me the other day, you go to the video store, the video section, and then you choose a background.
Okay.
Right. You
Actual
go to
background.
go to the bottom of your screen at the bottom left. It's next to the video. You see the video
Yeah.
camera? Okay, there's a little menu next to it.
Okay.
If you open up that menu, you'll see choose a virtual background.
Uh-huh.
Okay, and then you can click on that. It opens another window. It says pick your virtual background.
Okay. Okay. That's
You can
fine.
search on your computer and put any kind of background you want.
It's nice. Okay. That's great. Yeah.
You want to try it?
That's okay. No problem.
Okay, maybe after I can show you.
Yeah.
So, Axel, I'm going to mute you. Khalif, I'm going to mute you. Parth Joshi. Okay, everyone on the panel, we're going to start. And when I introduce you, please unmute yourself. Unmute. There's a button on your smartphone, Axel. You just click the unmute. And Amir knows how to do that. And Natalie knows how to do that. Everyone else knows how to do that. Let me get the... Where are you from, JK? JK, do you mind if I call you JK?
Yeah.
Yeah. Are you from New Delhi?
No, I'm from Coimbatore in Tamil Nadu. It's a southern India.
Oh, okay. Very
Okay.
good. Okay, you ready to start?
Yeah. Let's start. Yeah.
Okay, 10, 9, 8, 7, 6, 5, 4. Good day. This is Dr. John Bennett from Miami Beach. We have another episode of Neurosurgery Super Sunday for November 3rd, and we have the pleasure today of having JKBC Parthaban. He's a neurosurgeon from India. He's going to present on cisternostomy and post-traumatic cerebral edema. And let us first, can you get off the screen share, JKC? I'm going to introduce the panelists now.
Oh, okay, sorry.
Yeah, you just put, get off screen share there. There you go.
Yeah.
Okay, good day, Axel. How are you? Could you please introduce yourself? Axel Nomo, can you please introduce yourself?
Yes, good morning. Good morning to everybody. I'm Axel Nomo, fifth-year medical student from Cameroon, and I will be happy to follow your presentation. So good afternoon to everybody.
Very good, Axel. Welcome from Cameroon. And Khalif, welcome.
Good afternoon. Greetings from Nairobi, Kenya. My name is Khalif. I'm a fourth-year resident at Aga Khan University Hospital, Nairobi.
That's quite a background he has too. Amir, welcome back.
Good afternoon, Mr. John and everybody. My name is Amir Badran. I am from Ukraine. I'm a head of neurosurgical department.
Well, welcome, Amir. And Dr. Wow, welcome back.
Oh, welcome, Dr. John. I'm Dr. Wael, a neurosurgeon from Sudan. Hi there. Good afternoon, all.
And welcome, Dr. Wow, and our old friend, Dr. Kabulo.
Okay, thank you. My name is Kabulo from Democratic Republic of Congo. I'm currently final year neurosurgery resident at the University of Zimbabwe.
Welcome, Dr. Kabulo. Nathalie, are you there? We can't hear you, Nathalie. Can't hear. Whoop. Okay, that's okay, Nathalie. That's okay. Nathalie is a general practitioner from Cameroon. She's an active participant, and we're glad to see her. Ibrahim, are you there?
Yes, hello everyone. This is Ibrahim, medical student, PhD student, 5th year in Berlin, Germany.
Okay, welcome back, Abraham. Parth Jossi, we haven't met you yet. Parth, are you there? Go ahead, Parth.
Okay.
Go ahead, please introduce yourself.
Hello, can you hear me?
Yes, we can hear you.
Yeah, I'm not able to get the video actually.
That's
just a
okay.
second.
We'll work on that. Could you please introduce yourself?
Yeah, I'm a DNB neurosurgery resident. Just finished my 2nd year, currently in a 3rd year from Hyderabad, India.
Okay, welcome. And Bala, are you there, please? Could you please introduce yourself? Bala, are you there? There you are, Parth. The video's working.
Okay, thank you.
Okay, Dr. Sheenius, are you there? Perhaps not. Sagar, are you there, please? If you can. Well, they may have stepped away. Okay, there's Ipe. Ipe, how you doing, Ipe? Please introduce yourself.
Hi.
Hey,
Hi.
I'm Dr. Good to see you all.
Nice meeting you.
Okay.
Hey,
Okay.
Patty, good to see you.
Yeah.
Hey, welcome. We have a diverse group here, right? Okay, JKC, it's all yours and welcome. Could you please say a few words about yourself before you start your presentation, please?
Oh, yeah. Thank you, friends. I'm Dr. Parthiban, Juti Parthiban from India. I practice in Kovai Medical Center in Coimbatore. Yeah. I also get involved in the Neurological Society of India and also a member of a WFNS Spine Committee. And a very good friend of Ipe Cherian, and now we are one of the groups, largest groups that are working on cystinostomy. It's a very proud moment to be with all of you. And it's a wonderful day. It's a nice evening here in India. I hope that it must be a different time in other parts of the world, but it is nice to see you all. And I have to thank John for getting everything done for all of us. Thank you, John. Yeah.
Welcome.
Good.
Welcome.
Yeah.
Okay, can you start your presentation, please?
Sure. Thank you. Yeah. Are you able to see my presentation?
Not yet. Not yet.
No?
Not yet. You'll get it. You did it before.
1 second.
Okay, now we can see. Okay,
You can see that?
yeah,
One second.
you just need to open your PowerPoint. There you go. Open it up. Okay,
Right.
there we go.
Okay. Now, I see all of you guys on my left side. It is on my vision, my view. How can I reduce that?
No, it's fine. It's fine now. It's fine. We're seeing
It's okay.
it. Yeah,
But
yeah. We're seeing the big screen. It's fine.
I have it on my screen. Yeah.
Okay.
I have it on my. How can I?
No, it's fine. You can see the presentation. Well, we can see it. It's fine. It's big.
Okay.
It's fine.
But I see a little bit obstructed on my side, left side.
All you see is what do you see?
I see 5 panelists, including you, on my left side.
Okay.
John, I think he needs to minimize the boxes that show the participants.
Yeah,
You put your cursor on top of it, and then there's a
I'm
way you
trying.
can minimize it.
I'm trying, but
At the
I'm
top.
not able to.
At the top of it, or exit full screen first.
Okay, right? It's okay now?
No, we're not seeing
Oh,
it
it's
now.
not okay now.
We saw it before. We see it fine. We see it fine.
Now you're seeing I'm okay now.
Yeah, okay.
Are you seeing my slides?
Yeah, I'm seeing cystonostomy and post-traumatic cerebral edema. Big slide.
Yeah, thank you very much. It's a wonderful topic, and a topic which we all love to talk about. Cystonostomy in post-traumatic cerebral edema is catching up in our country. Thanks to IPE for the first introduction over this subject. Now, I come from this part of the country, India. It's a southern part of India, Tamil Nadu. I work in this hospital, this Kobe Medical Center Hospital. It's a very large hospital with 850 beds, and it has about more than 50 beds for neurosurgery, and it's a big trauma center too. When we started on cystonostomy, I get this very frequently asked some questions. Everyone asks me, what is basal cystonostomy? Why in head injury patients we do that? How it works? Is it possible? Or is it better than the established method in cerebral edema? Or can it be done as an individual procedure for cerebral edema? So these kind of questions we keep getting it. When we start presenting on this particular subject, this is how we get, these are the questions routinely we get, but let me see how we can answer this at the end of my talk. Now, this is the basic slide which shows that cerebral edema, and this is how we are being taught. The cytotoxic edema, the other one is the extracellular space edema. It's a very common thing which we all have read about it. However, it's becoming a big challenge to treat a massive, very severe cerebral edema because of the challenges we face for each and every patient, like medical management. Then we rely much on the ventilation and then the surgical procedures. So the surgical procedure comes after the medical management and ventilation, and so on and so forth. When you see the surgical techniques, we all know that the basic surgical technique is just supposed to remove the hematomas, the contusions, whichever we find it, which gives more edema to these patients, like extradurals, subdurals, ICH, hemorrhagic contusions. The decompression of the concerned edematous cerebral and cerebellar hemispheres should be wide and large. That's what being done for years and years together, like decompressive craniectomy, and then you open the dura. Now, this is how the treatment is being followed and being taught to us, and we are using that for every other day. But at the same time, we also have to think about something called the CSF release procedures. As we know that the CSF can be released in many ways, like you can open the sulcal surfaces of subarachnoid openings. You open the small sulci, and then you get a lot of CSF coming and seeping and oozing out. But this is not very common in all cases. And similarly, you can also try to open the Sylvian system. But if you see the Sylvian system and the sulci opening, it's very, very difficult when there's a severe edema. Then comes the cystonostomy. The classical cystonostomy is called as basal cystonostomy. The reason for that is those systems on the surface we are not able to open. So we have to go to the base to open the systems to let out the CSF. The other thing is the external ventricle drain, that when the ventricles are dilated with a locked up CSF. All these procedures above are not new. They are being done earlier, but without knowing what is happening. So in the process of this 100 years of education, the hypothesis is that the CSF is always produced in the ventricle and drained, as you see in this my slides. It runs through the ventricle, it comes out of the third ventricle and fourth ventricle, and then circulates over the subarachnoid spaces. You can see the amount of CSF which goes around the brain, under the brain, and over the brain, and then get drained through the villi into the sinuses. So this is the classical hypothesis. This is the hydrodynamics of the CSF, which we have been taught so far. However, the studies have shown that much more things are happening in other places, like the cisterns are finally connected to the Virchow-Robin space, from where there is a perivascular subarachnoid spaces. These are the perivascular subarachnoid spaces. These fluids, they dissipated into the white matter. Now, this is how the CSF is considered and understood to be produced everywhere. So why this is important, how this is important. And this is called the new working hypothesis. We call it as the glymphatic pathway. Now you can see very nicely from one side to another side, the CSF, the flows to one side to another slice and then drain out. Now this is the common systems, and commonly what happens in the glymphatic pathway is that there is some sort of a transparenchymal fluid, transparenchymal fluid traversing from these perivascular spaces into the white matter, and then later on it gets drained out. So this is a very interesting aspect. And so in head injury, what happened is that this gets disturbed. And so the elevated pressure gradient in the cisterns causes decrease in this glymphatic removal of interstitial fluid, thus causing the shift of the fluids from the cisterns into the extracellular space at Virchow-Robin space. And this is the hypothesis. Now, how do we come to this hypothesis? This hypothesis, so nothing comes out just like a miracle, it all comes with some scientific proof. Now, in these experimental and clinical evidences, which are given in some of the papers, you can see it is being proved beyond doubt that there is a dynamic of the glymphatic system in VIVO using 2-photon microscopy in mice, that the CSF enters the brain along the cortical pile arteries and proceeds to the parenchyma through a facilitated pathway, that is namely the VRS, the Virchow-Robin space. These images which shows of CSF tracer movement on AQP4 knockout mice reveal 65% reduction when these AQP4 is knocked out. You find there is a reduction in CSF of fluid flux through the parenchyma compared to the wild type control mice. This shows that there is some pathway which helps in pushing this fluid into the parenchyma. And when you knock out that, then you find it is not going through. So this is scientific evidence. The other evidence, experimental evidences done in Calgary also showed, in conclusion, the MRI images and subsequent histopathology examination clearly reveal that the shift of the CSF from the cisterns into and around the brain parenchyma, whereas no blood was found to be present in the brain matter. So only the fluid shifts in. So brain matter is brain. You see the blood is not coming into the parenchyma, but only the fluid. So that is where the fluid is getting from the subarachnoid spaces, from the basal cisterns into the parenchyma, and that causes the edema. Now you can see this is the drawing which I've done. You can see very well that the cisterns are there, large cisterns, it enters, and finally it becomes the Virchow-Robin space, perivascular spaces. And you can see the gyres are very nicely seen. Now what happens if the cisterns are filled up with subarachnoid hemorrhage following a head injury? The pressure that's being get blocked, the CSF get locked under high pressure and seeps into these cisterns, reaches the Virchow-Robin space. Through the Virchow-Robin space, gets into the white matter, in the process creates a cerebral edema. Now, this is the hypothesis, and this hypothesis is the rationale for the development of cystostomy. Now, the subarachnoid space, if you relieve the subarachnoid space, as we do in aneurysm surgeries, these CSF will come back. Now you can see some of the images which I've taken. I compared this with the tsunami waves. This is very, very simple. Now you can see these images which shows before the wave attacks the waves on the left side of your picture. You can see before the waves enter the canal, it enters the backwaters and seeps into the living area. Now, when the waves recedes back, the fluids get back, and those main lands become dry. Now, this is a very basic principle. So when the waves enter, like here is another view of, these are all satellite views. You can see the backwaters of a sea and the land. When there is high pressure tides, it gets into the backwater and seeps into the land and then gets back. So it's a classical one, it's a basic one. But similarly, this is what happening in our head injury also. So this is what I was imagining, and I feel this sounds very logic in explaining this issue. So when the tidal waves recedes back, the pressure into the backwaters recedes back. This is the rationale. This is the rationale of seismostomy, and this rationale was invented by Ipe, and when he was discussing with me, this is the point which he was telling, and there is a scientific proof which we saw in the previous experimental studies. Now, when I take back the history of seismostomy, you can see that in seismostomy was initially first, it was described by Ipe in 2006 in Nepal, and it was a serendipity, because he took it a head injury for an aneurysm surgery, an aneurysm. He opened it and he found that then the brain started relaxing and started thinking. As far as I'm concerned, we have been doing seismostomy. We have been doing opening the cisterns when we do the bifrontal craniotomy for bifrontal contusions. When we release the bifrontal contusions, we open the cisterns, the brain gets relaxed, and subsequently we put a facial lateral graft for the anterior cranial base, which every surgeon may have experienced this, but do not know how to hypothesize the reason for the edema. I has thought over that with the serendipity in 2006. Subsequently, it was taken up by some of the important doctors from all over the world, like Roy Thomas Daniel. He started doing in 2015 as regularly. Myself from India, I started doing from 2016, and Yonghong Wang in China in 2017. These are the three people who took it very seriously and started performing seismostomy and traumatic brain injury regularly, and started presenting and publishing as I'm doing it now. Now at present, this is not only stopped with a few neurosurgeons, but it is done more than 40 to 100 neurosurgeons at the time when I'm speaking at this lecture. I'm sure that more and more people are doing now seismostomy, having understood the basic, the pathology and the pathophysiology, understanding, because of the better understanding, you started doing it. However, it is being considered as a very complex surgery. It is being considered as a very complex surgery because it demands surgical skill and microsurgical training. And some people say it is not possible in all cases, and at the same time, it is not feasible practically in all places. Now, here, it is not possible in all cases. Yes, it may not be possible in some of the cases, but it is possible in all cases. When you start doing it, then you know better and better how to do this procedure. I'll show you. Now, this is the basic anatomy. You can see the basal cisterns. Basically, you can see the supratentorial and infratentorial. In the supratentorial, you have the carotid cisterns. You have the carotid and optic and carotid. This is a very important area. That is a common area we enter in. That is the opticocarotid cisterns, interoptic cistern, and lateral to the lateral carotid cisterns. And subsequently from there, you can find this liliquous membrane that divides the supratentorial and infratentorial by two layers very nicely. So if you wanted to open the CSF from the posterior fossa, that is from the infratentorial region, we have to open the liliquis. You can see in this picture very nicely, the liliquis is in blue in color. You can see the diencephalic leaf, and there is also one mesencephalic leaf, which is pink in color. And these things divide this into supratentorial and infratentorial compartment of subarachnoid spaces. And subarachnoid hemorrhage fills up all these places, the back theory, and it forms the the hypothesis is true. Now this shows a diagrammatic representation. The regular neurosurgeons who do the brain surgery for cerebral edema, they do not use microsurgery and very often, so just do the decompressive craniectomy. And it is very difficult for them to reach the basal cistern. So first, if you wanted to reach the basal cistern, you must be a microsurgeon. You must use microscope in this operative procedure. So cystostomy is basically a micro neurosurgery in trauma surgery. So that we have to understand first. And you cannot attempt it on the naked eye surgery. So that is the basics of all this thing here. Now this picture shows very beautiful anatomy of the basal systems. You can see the optic nerve and the carotid, and between the optic and carotid, you can see the arrows which are showing the liliquis membrane. The liliquis membrane, as you see on the left side corner, down corner, is very, very thin, and you can see through, you can open it very nicely. I'll show you in my videos. And on the right side, you see the diagrammatic representation of a very common and popular slides of the liliquis membrane. Now, subsequently, the techniques of the neurosurgeon has to change, because if you wanted to go close to the basal systems, then it is better you remove the a good amount of lessening of sphenoid and also anterior clinoid process if needed. But majority of the cystostomy can be done without that. But if you do the lesser wing of sphenoid removal, then you come very closer, and you can expose the basal system much easier. So this is where the contemporary thinkings are going on, and this is the difference with many of the neurosurgeons who are debating on this subject. Is keep talking about how we can go there. Is it possible? Yes, it is possible. It is a skull base. It is a skull base approach. So you may have to change a little bit your views on this particular surgery. Now here is the diagrammatic picture. You can see here. That is the lesser wing of sphenoid. And once the lesser wing of sphenoid is open, you can see the opticocarotid system very nicely. Now this is the operative picture. I am showing the operative picture. On the left upper corner is the patient position. On the right upper is that you've done the craniotomy frontotemporoparietal, a large one, as you do forever, and you find the lesser wing of sphenoid projecting out. That projection is the one which makes many people difficult to reach the base of the skull. Now when we push it extradurally, and then you drill it out and go as much close to the anterior clinoid process, and if needed, you can remove the anterior clinoid. If you have much skills, you can remove that also, and that gives very nice opening. And as Dr. Ibe says, it is de-locking the frontal and the temporal lobes. So this can be done. So you don't need to worry about it. These are not very much difficulty when you do the head injury patients, unless if you have a very good patients and you have interest in doing much better operation for cerebral edema, then you have to do this. Skull-based surgeons will love to do this. Now, subsequently, after opening, you can see all these are microsurgical pictures. On the left upper corner, you can see the optic nerve and carotid, and there is a mild retraction of the posterior frontal lobe. You can see that. And then so on the right upper, you can see the optic nerve is slightly retracted to expose the liliquis membrane, which is seen mild bluish and gray. And once you open it, that you go into the infratentorial region, we can see the basilar artery. And in that region, after evacuating enough of CSF from that place with good amount of saline wash, You can put a drain there. You can put a drain there, keep it and leave it out to drain the CSF in the post-operative period. Now, this is my famous picture, which I always put that, right? When you start doing your surgery as regular, and you start loving that procedure very nicely, you all know about Taj Mahal. When you enter the Taj Mahal looks like what we see in the mid center. Now, when we go around the Taj Mahal, it looks different. And similarly, the basal systems look differently in different approaches. So that is very important for the microneurosurgeons to approach the cystinostomy. So if you don't understand this, everyone will keep debating on how it is possible, how it is not possible. I'll show you some of the pictures. This is the picture which I appreciated, that you can see each pen, a frontal approach, the Tyrian approach, and lateral approach. So you see the optic nerve and carotids in a different fashion. When you see in the different fashion, your idea is microsurgical dissection of that region. So every time you see the optic nerve, it will look different from the frontal approach, Tyrian approach, and lateral approach. Like you see here, there's a patient with a frontal hemorrhagic contusion, which is enlarged, and that has been on the right side. You can see the post-operative picture. The frontal contusions are evacuated and cystinostomy is done. Bone flap is replaced in this case. And this patient has improved from GCS7 to GCS10 and is being discharged. Now, this is my video. You all may have seen it, but I would like all of you to see it again. This frontal contusion is removed. The frontal contusions are removed. The moment we remove the frontal contusion, we get a space, and that's the optic nerve. The optic nerve must be gently handled, and you can see the arachnoid. So you can see that can peel out gently. This is medial to the optic nerve, interoptic systems. You open it very gently. You have to keep on putting the saline, and you can use a blunt scissors, micro scissors, to open the arachnoid gently. That is the pituitary stalk. That's a pituitary stalk. You can gently peel it out, and meantime, you can see the CSF slowly gushing out. The CSF keep on coming. You should be very patient. Now I'm going on the lateral side. You can see on the lateral side, arachnoid is gently peeled out. Basically, it is a microsurgical procedure. The arachnoid is very nicely peeled out. And now we can see the carotid artery. Yes, yeah, you dissect it very nicely. Now again, you can see between the carotids and the optic nerve, you find the Liliequist membrane. And this Liliequist membrane must be opened gently, and you can get into the infratentorial compartment. Probably you can see one of the posterior circulation vessels. Here we can see the basilar artery. So saline wash should be given very nicely. Further you can dissect, because Liliequist has got, it's a much forwarded, you have so much of forwarded of this vessel. So a good dissection, a good liberal dissection, you do not limit it. Once you start doing it regularly and good wash, you find the complete CSF start coming out. So here in head injury patients, you not only do a good surgery, and also you can enjoy microsurgery. That's very important for young neurosurgeons, I would like to say. So everyone should become a microneurosurgeon from the beginning. The training is important. Like, the basic training is microsurgery for all neurosurgeons. Now we have to use that microsurgery in trauma. Now you can see that the more you dissect, the more space we get at the basal. Now you can see the opposite optic nerve, you see the chiasm. The brain is so much lax. So this is another patient. You can see this patient here, right frontal contusion, and after surgery, the brain is much lax in this case. Yeah, these are the pictures which you can see, the microsurgery pictures, the edematous brain, and then this is a Tyrian approach. You can see the frontozygote, you can see that the upper right upper corner, you can see the directions. You can see the optic nerve is slightly look different from what we saw in the previous picture. Now you can see very nicely this chiasm there, the complete apparatus, optic apparatus. On the bigger, you can see the chiasm, the optic nerves, and lateral to the carotid, you can see the Liliequist membrane. And this Liliequist membrane can be opened and the drain can be placed. So the moment you change from the frontal to the pterianal approach, the optic nerve and the chiasms look different, but your basic technique must be the same. Meticulous dissection with lot of copious saline irrigation will let out the CSF come out. Now, another case with the temporal hemorrhage, subdural hematoma, massive edema. This is approached through the lateral approach. This is a post-operative picture on the right side. Very nice, relaxed brain. You can see that, and you can also see the drain in front of the pons. There, you can see the drain coming on the right side of the CT scans. You can see the drain which is coming up. Now, this is the operative technique on the lateral side. Now you can see that the maxilla, that is the zygomatic, that is the arch, is always kept very high. And this is very important. Many times I watch these trauma surgeons, they just keep the patient just like that and then do a large DC. But here in all my patients are done as if that we do for aneurysm surgery. Now, because we need to go to approach and reach the basal system. So the brain has to fall back. This is an important technical point. So I use it regularly and which very much easy. These are the points which will definitely answer the questions whether this particular basal system can be done or can we approach the opticochiasmatic, opticocarotid systems at all. Now this is another case. You can see so many cases I can show you. So many cases I can show you. You can see the right on the lower corner. Right on the lower corner where you can see the opticocarotid left side, and there is a drain. It's a beautiful drain. All this thing is done. There is no retractor. You have to watch these pictures. I don't use any retractor here. You can see my left hand, the suction is there. The suction is enough with a cottonoid, and that is taken as a retractor with copious amount of saline pushed down. Now that is the video. You can see here. You can see here. This is drain. This is the drain. I'm opening the drain now. You can see that, right? Next slide. Yeah. I like to show you this. There's another video. Why? The reason of showing all of you, the young doctors, to so many videos. This is slightly speeded up. It's normal. It's not a normal speed. It's double speed. But you can see the technique, how I do the optic nerve and lateral to the optic nerve. This must be completely gentle. There is no retractor. Again, I'm telling you. I don't use the retractor. I use only the suction as my retractor. Many people get surprised. How do you do that? It is very possible because the ventilation gives me a much relaxed brain, but at the same time, my technique makes me possible. Once I start reducing, once I start releasing the CSF, then and there, and slowly, slowly, the brain relaxes itself. It allows it. That is the A1 you see. Now you can see this is an interoptic region. I open most of the basal systems in anteriorly. I try to open as much as arachnoid as possible with copious amount of saline. With copious amount of saline, you can see that. The reason for showing the large number of slides and the videos is so that the surgeons will understand, yes, it is possible. Yes, it is possible. There's no question that whether it is impossible, I cannot retract. No, majority. I have feeling that majority of these patients, it is possible. And in most of the patients, I have taken the lesser being of sphenoid. Anterior clinoidectomy is needed when in very, very difficult situation. If I can't, then I will definitely do anterior clinoidectomy. Now you can see that post, how nicely, how much the brain is relaxed. Very much relaxed. You can see that that's a drain and it's very much a relaxed brain here after the decompression. This is another video. You can have a video. Look at that. There's a here now. I use the retractor. You can see this is the retractor. I use a little bit, then subsequently we completely remove it. Now, again, you can see after that I remove the retractor. Again, my suction comes, optic nerve, carotids. So you keep on doing it, you become a master. When you keep on doing the technique day in, day out, one case, imagine, I was wondering about, IPE has done 1,000 cases. So it becomes like it's a child's play. Now, if you have not done a single case, then you'll find it is not possible. But if you keep doing these cases one by every other case, it becomes like a child's play. So the masters, they do it very easily. See the amount of CSF being gushed, saline wash. Now that is the lilyquist. You can see the layers. Lilyquist, you can open any technique you like. You can use your micro instruments, micro scissors, or a very sharp instrument. So you have to be very gentle. Your microsurgical technique should be very clear. Finally, that is my point. Your technique should be very gentle. It is a microsurgery. It's a skull-based surgery. No need to get worried about it. No need to get scared that, oh, I'm not able to do. It is possible. You just have to wait. Now you see again, there is no retractor. So only the suction will be there. And the amount of retraction I get is amazing. Amazing. You can see that. This is to demonstrate to all the young doctors that I give confidence that yes, this procedure is possible. So this is between the optic nerve and the carotids. Again, I'm opening a much opening. Then I'll put one drain over there for the CSF. Yeah, that is the place. I put the drain there gently. Yeah, and keep the drain and bring it through outside and then fix it. Now you see these pictures. Before operation is very decompressive craniectomy, cerebral edema, the brain coming out. You just do cystinostomy, the brain gets lax and put back the bone flap. It is possible. You can either float it or just put a bit of a fixation, light fixations to accommodate the edematous brain. Now this is another case. You can see the pre-cystinostomy. On the right corner, you can see the post-cystinostomy. The relaxed brain is in comparison. Now, many people ask me, how will you keep the drain post-operatively? I keep it down and allow as much as CSF to come down per day, 120, 150 cc's. We get it, we are very happy. If the drain sometimes get obstructed, you have to flush it out with 1 cc of saline, and that again you can start getting enough of CSF. Now, in some cases, in spite of all these things, we do get this type of patients. And if you get this type of patients, you are sure you understand that the edema, the primary edema is very bad. You can see on the right lower corner, even though I have done cystinostomy, in this case, I have done cystinostomy, there is a CSF coming, but this CSF will be very thick, mixed with a lot of blood. And usually these type of patients, they don't do very well. This is a very rare kind, and you try this type of patients even in acute form. Sometimes we do get this kind of cases. So basal cystinostomy is a microsurgery. Opening lilyquist membrane drains CSF from infratentorial resistance. It is more than complex. It is essentially a technical issue. It's a technical skill that is needed. It is possible in majority of the head injury patients in most of the cases. Clinodectomy is needed in special cases. So you should be trained well. You should be very trained well in skull-based surgery. That is very important, my point. Now, CSF drainage. This is basically, some people used to say, they call it in a very much, I don't believe this, but I personally feel you must understand as a neurosurgeon, it is a CSF drainage procedure of high level with the background hypothesis and what we are trying to tell to everyone. Many people are not able to understand the concept behind it. And so some people may criticize, but I'm not bothered about it. This technique is seen as complex, but it is not. It is doable. And it is done all over the world in recent years. It is not that. It is so the answers are coming. By 5 years down the line, it's already up. 5 years down the line, it is going to be more popular. And actually, I have a lot of respect to IPE. If you go through the literature, there are so many papers written by him, and some of the papers everyone should read. Some of the papers, so you can see Clarica paper, you have to read. This paper has to be read and understood by all residents. This is about 30 pages of very large research review. One has to read about it, then you'll understand why this surgery is being done, why it is being revoked now. And I like to also tell about this, the latest research publication done by our team under Dr. Ipe, and this is the very beautiful paper. You can also refer to this paper, Cystinostomy, a timely intervention in moderate to severe traumatic brain injuries, the rationale, the indication and prospects. I'm absolutely sure my talk has given most of these answers, and I've come to the answers here. What is basal cystinostomy? If you don't believe it, take it as an old and established procedure, revoked now. Why is this head injury in patients? Because we are letting out the CSF, and so the CSF shift edema, that is the reversing the CSF shift. How it works, it reverses the edema which has happened because of the pressure inside the Virchow-Robin space. Is it possible? You have seen the videos. Yes, it is possible. Is it better than the established method in cerebral edema? Yes, it is. You will get the results in coming years. Can it be done as an individual procedure for cerebral edema? Maybe. It is possible. We are working on that. We have to select some few cases, and we are planning on which case we have to do only cystinostomy, completely no bone removal at all, without doing that completely skull-based approach. Maybe sometimes it may not be possible in all cases, but it is possible in majority of the cases. Last year, as Khalif was showing that the symposium cystinostomy with the history was first done in Beijing in 2019. It was a great moment, and it was because of the leadership of Ipe Cherian, and we were very happy to participate in that, and it was a wonderful time. And so naturally, Ipe is very happy with Yong and myself. We are very happy to give this lecture to all the youngsters in and around the world. Thank you very much for listening. Thank you.
Thank you very much, Dr. Parthaban. Excellent. I guess Ipe is the most appropriate person to lead this discussion. Ipe, can you lead the discussion and introduce your associates before we start?
Yeah, Pati, fantastic. I mean, I couldn't have said it any better. I mean, all my lectures over the years, I can say that your lectures are always much better than mine. So, and I see that Wang and Roy is also, their lectures are also much better. I would have done it in my real crazy way, and people would have, as usual, said, shaken their head and said, this guy is crazy. So, I mean, it's great to have people like you doing this. And I see the videos and I see it's how beautifully you're doing it. So I'm very happy. Now, this is Andrea Girosa from Italy. And he's a neurosurgeon, and he's been with me for some time now. And this is his second visit to Nepal. So he's seeing some crazy cases here. And that is Prochizia. Prochizia is from Tanzania. Prochizia will become a biomedical engineer, and we're working on the new scope that we're developing, as well as the water knife and many more other things that I believe that now is the time for neurosurgeons to collaborate with biomedical engineering and move forward, because these are two different branches, and unless we have an understanding of engineering as well as they have an understanding of neurosurgery, it's difficult to develop new things. Otherwise, we will end up with microscopes which are a pain in the ass, and also QSAS, which nobody understands how to do it. So they have to see the procedures, and we have to tell them how we want things. So this is, and she's from Tanzania. I hope someday she'll go back to Africa and she will make a company and be the CEO of a company which will produce very cheap and fantastic microneurosurgical instruments. Now, as far as my talk goes, I have two short talks. I was supposed to do the pituitary, I will do that, as well as 2 days before we had a difficult basilar tip aneurysm. So it is the same procedure that Bharti had shown. So we will just show the clipping of that basilar tip as well as the giant pituitary adenoma. The giant pituitary adenoma was having a cavernous sinus invasion, so we went transplanar. We went posterior to the C3, the horizontal. The vertical carotid in the paracellular region. We went posterior to that. We went between the C3 and C4 and evacuated the cavernous sinus portion, as well as we went transplanar and took out the suprasellar region. The patient had only finger counting very close to her face initially, and at discharge she was completely all right. All the tumor was taken. Maybe I can ask Andrea Girosa to present on this case, and then I will present on the basilar. Maybe I can first present the basilar, and then Andrea can present the. So maybe I will share my screen. Okay, so here is in operator cases or basilar tip. Ruptured basilar aneurysm. This one. Okay, can you guys see my screen?
Yes. Yes.
Okay.
Yeah, we are.
So,
You're not. Are you opening the video now? Okay.
I will open it with the VLC.
Whoop! It didn't open.
Yeah, it will open now.
Okay. Still no.
No?
It looks like it's loading.
Okay.
Yeah, there we go.
Yes. Yeah, so I'm going to. So that's a very short video. So, let me just first show you the basilar tip aneurysm. Now, okay. This is as stubborn as I am, but I'm more stubborn. So, you see, that is the aneurysm. You can see that. And these are the two P1s. That is a basilar. There are two small superior cerebellar artery aneurysms. This is, superior cerebellar arteries. That is a PCOM. And this aneurysm is pretty high, and it's posteriorly projecting. So because it was high, we wanted to get a projection from low to high. So we had to take off this long clinoid. You can see this clinoid is really long. So we took off this clinoid. We did a transcavernous approach, and you will see how it is done. Yeah, so we have already cut the orbitomeningeal band. Those who have seen my lectures and earlier would be familiar with how the orbitomeningeal band is cut, and then you have the cavernous sinus there on that side. Here I am cutting the dura. This is called the hybrid approach, where if I'm not familiar with where the carotid is, then I can just cut and have a look as to where the carotid is. And also, we are in the cisterns right now. You must understand we are right in the base of the brain, what Bharti was showing. Extradurally, I can get into the cisterns there, so that helps in many ways. One is to get into the cisterns, as well as see intradurally what is happening. So that is the last piece of clinoid being taken out there. And after you take out the clinoid, you have the oculocarotid membrane, carotico-oculomotor membrane, and then you can see that there. That is the carotid there. So now dural opening, and you can see this is the optic nerve. So you're cutting the arachnoid, and then now you have, that is a cavernous sinus there, and that is a tent. That is where the third nerve is going into the cavernous sinus. That's the third nerve. And now I'm going lateral to the carotid. That's a PCOM. And you can see the clot, Lilliquist membrane is filled with clot. And so now I'm opening the opticocarotid membrane, just trying to develop this plane, making sure I don't cut the ophthalmic. So proximal sylvian dissection is also needed here. So we are doing the proximal sylvian dissection as well. slowly expanding the corridor more and more. And now you can see the liliquous membrane that is between the third nerve and the carotid. You can see the liliquous membrane is being developed now. Now I'm going between the opticocarotid membrane, opticocarotid window, and I'm developing this plane. So cutting the liliquous membrane and getting into the basilar artery now. So that is the basilar. And now you can see clearly, I will show you the third nerve on the contralateral side. Anything above the third nerve is P1. So remember this dictum. This is the only truth in neurosurgery, in posterior fossa surgery. You can see the white thing, that is the third nerve, and above the third nerve is P1. So if this is P1, that's a contralateral P1, there is a basilar, and there is aneurysm. So as we expected, posteriorly projecting aneurysm. So that is aneurysm. It is going into the interpedunculaire fossa. There is P1. This is the superior cerebellar artery. This is the basilar artery. And you can see now I'm dissecting between the P1 and the neck of the aneurysm. You must understand I don't have any proximal control here. We don't have space to put another clip, and you know, it's a bit difficult. It's a very small window, very high aneurysm. So we are dissecting between the P1 and the aneurysm, so that I get some space. So you have perforators here. You have to be very careful. I mean, if you are not kind to the perforators, they will not be kind to you as well. So you have to be very, very careful in dissecting this aneurysmal neck from the perforators. So earlier I used to, for the basilar tip aneurysms, I used to put in a small Surgicel and just push the Surgicel forward so that we can avoid the perforators. But these days I don't do this. So I've got a very good plane between the aneurysm and the P1. And now I will put the clip now. So this is the P1. I have a very good plane. I can see always there is a little bit of blind spot. If there are posterior perforators, there is a bit of a blind spot. But sometimes I dissect the whole aneurysm. If it is a basilar tip also, I can show you some of the videos where we have dissected the entire aneurysm free. We have taken the blood clot out and seen the rupture point and all that. It is much more safer than anterior circulation aneurysms to do this. But sometimes you really don't require this sadomasochistic procedures. So you can directly put a clip and you can straight away. Now I'm going to do this now. Yeah, so the orientation of the clip as well as how you put the clip is very, very important. This window is very narrow, you must understand. So you're putting a clip there, gently massaging the artery, massaging the aneurysm, and then putting, so first clip, not good. So we are going in furthermore. Always err on the side of being more gentle, not on the side of being more brash and more rough. So very, very slow, very, very slow, and just clip. That's it. So that is done now. So we will see now the post-op pictures. The patient is extubated. It was done day before yesterday. Patient is extubated. He's obeying commands right now. Scan shows, scan is excellent. So you will, that is a clipped aneurysm. There are arachnoid bands. These are not perforators. Don't think that they are perforators arising from the aneurysm. They are not. So that's a P1. That's one P1. That's the other P1. That's a basilar. And this is the same technique that Parthiban showed the cystonostomy. It is the same technique. You dissect more arachnoid and you will be able to do this. So instead of training for a decompressive hemicraniectomy, I think neurosurgeons, as Parthi told, as neurosurgeons, you should start to do microneurosurgery. And only you will not think that this is very difficult. And this is, you can see the superior cerebellar artery beautifully now. And you can see the carotid, the basilar, P1, and you can see distal to P1, there is no aneurysm filling. So you can see the superior cerebellar there, P1 there. You can see the basilar there. You can see the contralateral P1 taking off there. That is the basilar tip. And we are just demonstrating it to fellows and our residents that there is no aneurysm left now. Okay. Everything is good. Okay. And we would like you to see the post-op scan also. It is there. Okay. And no problem. We can show. It's okay. Yeah. We can show that. Do you have the post-op scan with you? Yeah. I can just show it like this. This is the post-op scan, and you can see the clip. You can see the clip there, and everything looks beautiful, and this guy is okay. Now, Andrea will probably show you an endoscopic resection of giant pituitary adenoma. Yes, Andrea, you can take over. Any quick comments or questions or anything?
Okay, we're not seeing the video yet.
No, you can. I was thinking whether anybody has any comments or questions about this one. This one.
Yeah.
Yes, Parthi, tell me.
It's excellent. Yeah, it's very nice. Like as I said, if the young doctors in neurosurgery, they start doing more basal cystinostomy, when they keep, if they keep doing basal cystinostomy, I'm sure that they can do better aneurysm surgery.
Yeah,
that absolutely very clear by seeing your the approach to the basilar tip aneurysms. Yeah, it's excellent.
Dr. Gabulo, you had a question? Dr. Gabulo, you had a question?
Yes, I have a question to Dr. Patiban.
Okay, yeah. Go ahead.
Okay, I have two small questions. The first one is about the liquid membrane.
Yeah.
I wanted to know which part are you opening? Are you going above the PCOM or below the PCOM? Then the second one, the drain you are leaving in after doing your cystostomy, are you putting negative pressure in the drain or it's just a simple drain?
Yeah. Okay. See, as far as I'm concerned, that when I see the liquid membrane, are you able to hear me, Dr. Kapura?
Yes, I can hear you.
Yeah. See, now you have seen my videos, right? Once I get into the carotid corridor, into the cistern, and the liquid, as I was showing, I try to open as much as possible. Now, whether it is inferior or superior, that absolutely does not matter, but then as much as possible, because I like to completely open and try to get into the posterior, that means the infratentorial systems. So that is the idea. The whole idea is that not to go to a certain level. Now, if you carefully watch, you'll also see between the carotid-optic corridor and also the lateral carotid and oculomotor, that region also. So wherever there is a liquid, we try to open it out, because subarachnoid hemorrhage is locked up everywhere. So it is better to extensively open it. So some surgeons, they advocate only a little bit, but I prefer to open as much as possible, as you saw in my videos. Even in the interoptic, I go close to the pituitary stalk on both sides posteriorly. You can see up to the posterior clinoid process. can see up to the post process and beyond. So, so it is an extensive dissection as much as possible. One. Number two, the second question, no negative pressures. No negative pressures. You just put the tube, that's enough. You should not produce, it should not be done. Yeah, no negative pressures. Are you okay?
Okay, Dr. Kubulo?
Yes, thank you.
Thank you.
Okay.
If I can add just one thing about the Lillekis membrane, it really doesn't matter where you open it, because the point of opening the Lillekis membrane is because in some patients, not everyone, but about 30% of the patients, the Lillekis membrane isolates the supratentorial spaces, subarachnoid spaces from the infratentorial. So in those patients, if you don't open the Lillekis membrane, the cystonostomy is useless actually, because you don't put in communication the supratentorial spaces with the infratentorial. That's the whole point of opening the Lillekis membrane.
Yep.
Yeah, well, Andrea, I would like to add that it is just not the 30%. We would like to open it in all patients because, because even though it is communicating, it is like the spider web. You know, you pour water onto the spider web fast. What happens is, it will let it pass, but it will pass it only slowly. So you want a rapid passage of water. So you want to open as many, you want to open as many arachnoid webs as possible. So we will open everything, but you said it doesn't really matter as to where we open. Lateral to PCOM would be in the in the carotico-oculomotor window, and medial to the carotid would be in the optico-carotid window. So in both windows you can. And I showed in the basilar-tip aneurysm how we open both windows.
Yeah, it's ideal, as correct. I think it's better to open as much as possible.
Conclusion.
We are not seeing anything now. We are seeing some.
Hello.
Yes, go ahead.
Are you seeing the video?
Yes.
Okay, so this was the case, this giant pituitary adenoma, and you're seeing the coronal and sagittal images. And we decided to go with an endoscopic approach with an extensive corridor and the transplanar corridor. Here you can see after the nasal stage, this is the vomer, this is the right sphenoidal ostium, and this is the left sphenoidal ostium that are being dissected. Now you will see that the superior part of the vomer bone is drilled and then removed, and this with a posterior ethmoidectomy is necessary for a good angle of work with the transplanar route that we chose to approach this tumor. Here is the drilling of the vomer. And actually the difficult part of this tumor was because the sphenoid sinus was a concal type. So you have three types of sphenoid sinus. A presellar sphenoid sinus, a sellar sphenoid sinus, and a concal type. The concal type you see is much less pneumatized than than the other ones. So the surgeon has to drill much more bone, and also the bony landmarks are less prone to be identified. Here you can see the optic recess, and maybe here, here, and the posterior. This is the posterior ethmoidal artery, and this is the sella region, and this is the tuberculum sella, and then the plan. So now you see that we are drilling all the bone in the sella region until we reached the dura, that now you will see. And after the bone is thinned out, you can remove the bone with a Carrison. And after extending the bone work in the sella region, we switched to the more superior part, to the tuberculum sellae and the planum. And so the planum was drilled, and also a bone cusa was used, as you can see now. And you see that the bone is very thick because of that concal sphenoid sinus that we talked about before. So again, after thinning out the bone, the Carrison roundery is used. Here you can see the superior intercavernous sinus that is being coagulated. So the hemostasis is achieved with the bipolar and the Surgiflow until we have a clean surgical field. And then here you can see the dural opening with the tumor bulging out. So again, here is the optic nerve. Here would be the carotid. Here is the planum that has been drilled out. And here is the stellar region. Correct me if I miss something. And so the tumor, luckily it was a soft tumor, a soft adenoma, and is being sucked with the, you can see two suckers, one straight and one curved, to reach the lateral part into the cavernous region. And the tumor is removed piecemeal. And after a while, now you see the hemostasis achieved again with some Surgiflow. And you can start to see how the arachnoid is starting to collapse. You see, this is the tumor, and this is the arachnoid membrane pulsating, still intact, so there was no CSF leaking. And here we are going towards the the deeper and superior part of the tumor that you saw on the pre-op MRI scan. And you see how the arachnoid just follows the tumor and start to bulge towards the surgical field. Again, the two suckers are used. The curved one is used to suck the deeper part of the tumor, and in the more lateral aspect. And care is taken not to damage the arachnoid to avoid CSF leaking. And here you see that in this area, we still have some tumors that we could not reach. We could not see very well. So now I think you'll see that we switch, yes, to a 30 degrees endoscope, yes, to see more clearly this residual tumor. And that part is taken out. This is the final stage with the reconstruction. Before the sphenoid stage, we harvested a Haddad flap. So now you can see here the tumors, the arachnoid membrane still pulsating with some surgery, and now the flap that will be fold in position. Some septal bone that is placed, and again some hemostatic materials are packed inside with fibrin glue. As I was saying, this patient would only see the hand very close to her face, and after 2 or 3 days after surgery, she now counts from 10 feet, yes, 3 meters, and this is the final result with the entire tumor removed. You can stop.
Okay,
Any comments
okay, don't be shy, panelists. Any questions or comments for our Ipe and Andreas?
And Andrew, it's very nice presentation. Now, in case if the tumor is a little harder, how will you do that? And because if it is a soft tissue, it comes down gently,
Yeah.
but sometimes it is rubbery and sometimes it is slightly harder, then it is pretty uncomfortable in those cases. How would you like to?
So in this case, I will go and one of the good things about heart tumors is that they don't go into all these spaces. So they are hard and round. So they are really hard and round. So the good thing about them is that you can use a CUSA. We have a long handle CUSA. So we use a CUSA. Sometimes I use a microdebrider. So, and I completely collapse. I make it only a shell. Once I make it a shell, then I can go extracapsular and start dissecting. But if it is hard, I'll get as much access transplanar, and laterally also I will get as much access as I can. And then once I collapse the tumor completely, I will, just like microsurgery, we will start dissecting it. But this takes much more time. And I always pray that the tumor is soft.
Yeah, I agree. Yeah.
Okay, that's the medical student has a question. Ipe, Nathalie, you have some questions? Go ahead, Nathalie. I don't know if her video and audio is working. Nathalie, are you there?
Yeah, I'm there. Can you get me?
Oh, go ahead, Nathalie.
Okay, I had a question first for Dr. Patiban.
Yeah.
Please, during the drainage of the CSF, we fear a hyper drainage. And
Well,
for how we fear a hyper drainage, that's the drain so much CSF that we reach hypo a hypotension.
No, it's very, I'm not able to answer for that because I don't know. Sometimes I get a CSF up to 120 ml, sometimes more than that. But I don't see much difference in my CT because we do CT scans quite often, even when the patient is in ventilator. We don't find much difference supratentorially when we drain the CSF from cystinostomy. So I'm exactly not able to say how much, but sometimes we drain up to 150 cc. I think probably, I don't know what's Ipe's experience in this. She's asking about hyper drainage, but I'm comfortable. The more the CSF drains, it is better. That's how I look into that. Nathali, are you able to get me?
Yeah, I would agree with him. Where are you from, Natalie? Which country?
From Cameroon.
Huh?
Yeah.
Cameroon.
Cameroon, I see. Okay, so yes, your question about hyperdrainage is very correct. You don't want to drain it too much. That can produce problems. So we generally put the drain because we think that there's a lot of blood. We put the drain at the bed level for 1 day or maybe 2 days, and after that we raise the cystinostomy drain to 10 to 15 centimeters. So then it takes care of hyperdrainage. So anyway, at up to 150 to 200 ml of CSF drains every day. So that is because it's blood stained and we want that blood to be coming out. That does well, but we really haven't looked into how much CSF can be safely drained, because CSF is also required, and this question is excellent. So maybe we will probably look into this fact. Thank you very much for the question.
Yeah.
I have a question.
Go ahead, Natalie.
Yeah, Dr. Ibe, I have a question for you. When you're putting the clip, how do you know or feel that the structure on the other side of the aneurysm is not jailed or incarcerated by the clip? How do you know? How do you feel that the clip has not taken the structure which is at the other side of the aneurysm, since it's not very visible?
Did you get the Ipe? Did you understand the question?
You're asking me about the blind spot, Natalie?
Yeah.
Yes.
Okay.
How do you know you have not jailed the structure at the other side? That's the structure that you cannot see at the other side of the aneurysm.
Yeah. This comes with a lot of experience, Natalie. So I must admit that in my first few cases of basilar tips, I've had some disasters because I could not really figure out what was on the other side, and I have clipped some things in the other side which was not supposed to be clipped. Perhaps, I don't know, because this is something that I'm blind to. But then as we do surgeries in this region, it's you get to know what is your depth and what are the structures, and you get to look at the angio. So you have a virtual vision from the angio that you're seeing, and you kind of know as to which way the aneurysm is pointing, what is your window. And when your clip goes in, you have you have a mental picture of how your clip is going in and what structures are there. So this is how you sort it out. It's by experience, and it is by developing a picture in your mind.
Okay, thank you, Dr. Ibe.
You're welcome.
Okay, more questions and comments from the panel?
Yeah, I have a question for Dr. Atherburn.
Go ahead, Khalif.
Yeah, I've seen that the craniotomy is you're doing a large bone flap for most cases. Is it necessary? Why do you do that? Why don't you just do a mini pterio, no?
Yeah.
And you
It's a
go
good.
straight, like the way you do for MC aneurysms, and then you put your drain there. Because what I've seen is that once the brain is decompressed, then there is no need for big bone flap.
Absolutely. See, it's a nice question because as a routine, we do the large flap. But if you carefully watch the dural opening is limited. We started limiting the dura very, very low. So even the subdural we wash subdurally. We don't open the dura. You can see the dura is open in a curvilinear fashion toward the base at the lesser being of sphenoid. So we reduce it. And the bone flap, that's where I was trying to tell you. The bone flaps, larger bone flaps are made to either to evacuate an associated contusions or large subdurals. But if they are not there, then as myself and I were discussing about it, that we do a small frontotemporal opening and then go to the skull base and just do only cystinostomy. That is so those cases we need to actually finalize what kind of cases we can select for a very small cranial. So the reason for doing that is not because it is as a routine, but in the practice. See, most of my, I think my students are there. They must be listening. They are all there. We ask them to do the craniotomy, and then subsequently we'll ask them to do the lesser being sphenoid excision. But the dura we open is very, very small. It has become smaller and smaller. Over a period of time, our surgical technique changes. So, and also, like you said about not only the standardized decompression for every case. For example, that you have only a frontal contusion, then you can do through the completely frontal approach with a complete, or whatever we do, we can do through only a complete frontal approach. We don't need a big craniotomy at all. Some of the cases I have not shown all my cases. I've shown only a few cases. Those cases which we see, if you carefully look, and in those cases, they have multiple contusions or hemorrhagic contusions in all over the frontal and also the temporal region. So these are the cases we do a bigger flap. Yep.
Okay, thank you.
Okay, very good. Any more comments or questions? Go ahead.
Khalif, which country are you from?
I am from Kenya, Nairobi. We met in Beijing in September.
I you like that background?
Yeah, I like that background. I see that. I mean, I'm talking in that background. I remember this.
Yeah.
For sure.
Yeah, show them that background. Look at that background.
Yeah.
Yeah, I took the picture. I was in the audience.
Next year, I am coming to Nairobi, and
Yes.
I'm going to spend some time in Tanzania. So I may be going to Kilimanjaro and maybe Tanganyika, and maybe Chizia here would be taking me around. So
okay.
I would also like to connect with some neurosurgeons in Tanzania, if you know them, so that we can come and maybe share our knowledge with them and learn from them, as well as if we can tell something to them that will be helpful to them, we can do this as well. So I hope to see you all in my visit to Africa next year.
Oh, we are hoping you'll come in our Cannes conference in August.
Yes, I am coming
we'll
from this congress. I will be coming from this congress for sure. And I am, after this, I am off to Tanzania.
Yeah, he's my prof, he's my boss. We'll be glad to have you. And I'm also hoping to come to your center sometime next year once you start the mentorship program. That is, we're waiting for December 15th. Yes.
Yeah, you're most welcome. You're most welcome.
Thank you, sir.
When is the Kenya conference?
It's in August 2020.
Okay, very good.
Continental Association of African Neurosurgical Societies.
Very good.
Yeah, we'll have a session for cystinostomy.
Oh, that's wonderful.
Yeah.
Hey, there we go.
Yeah,
There will be a plenary session. It will be a plenary session. Everybody should attend.
Yes, definitely. Yeah.
All right. Thank you, sir.
Thank you.
Okay, more comments and questions from the panel. Now is your chance to ask questions or comment. Go ahead, Raj.
Hello, good morning, Dr. Chorian. I'd like to ask you, what about the rate of CSF leak you have postoperatively?
2020.
Because as young neurosurgeon, I've seen like young neurosurgeon doing endoscopic surgery. We have a lot of complications like postoperative leaks?
Yes, you are asking about
your rate. Yeah.
The pituitary?
Yeah, the pituitary, yeah.
Yeah, when I started, my rate was very high. I must say, as a young neurosurgeon, my rate of CSF leak. So I used to open only a very, very small window so that I was very, I had some very bad experiences with CSF leaks and meningitis and patients dying because of that. So, but I later realized that with the Haddad flap, I mean, you really don't have to make a large Haddad all the time, but with the Haddad flap, with the ENT guys with you, and if the good Haddad flap is taken, then CSF leak is very, very less. So only in the last few years I can think about a good. Earlier I used to do microscopic surgery, and it was Roman Bojniak as well as Narayan who was instrumental in bringing me to endoscopic skull-based surgery. So Roman and Roy, they really encouraged me to start up endoscopic surgery. But when we were doing microscopic surgery, we were doing small openings for pituitary and even large pituitary, and there was a lot of blind stuff. So right now, what we are doing right now is the result of many of my friends who has kindly, taught me this. So I would say that we are just in the process of improving ourselves with this. While we are quite comfortable with open skull-based procedures, we are not as comfortable with the endoscopic procedures. So I should not be the person who should be answering about my leak rates and all that. Maybe somebody like Narayan or Chandrasekhar Pujari, who are more established in endoscopic skull-based surgery, they should be answering this. But if there is any question related to the basilar aneurysm, I think I would be eligible to answer.
Yeah, but the basilar tip aneurysm, like in the West, we are not doing it anymore. Like it's all like endovascular, or that's why I have to come to India or to Nepal or to Vietnam to go and see these procedures, because it's rare. We see a lot of ACOMs, like PCOMs, MCAs, but to be like, I did not see what approach you did, because I came later on. What approach did you did? Subtemporal or?
No. I did a transcavernous.
Okay.
I did a transcavernous.
Raj, could you introduce yourself? We don't know you.
Sorry. I'm a fellow in skull-based and cerebrovascular surgery in Montreal.
In Montreal?
Yeah.
Wow. That's great.
And I'm going to work as a consultant in Austria now, moving on.
Very good. Welcome, Raj.
Thank you. It was my pleasure. I could wake up and I was not on call, so I could wake up.
Okay, very good.
Yeah.
Okay, more comments or questions from the panel. Now's your chance. Well, I guess we tap the questions out, Ipe and JK. And I'd like to thank you all. Go ahead. I'd like to thank you all for coming. I'd like to also announce, Ipe, that the app is getting close to be done, and a conference like this you can see with one tap, and you're able to enter the webcast like this one on one tap. Right now, we're on the front page of the app. This conference right now is right on the front page. So
I would like to ask Dr. Cherian a question.
Yeah, go ahead.
For aneurysm clipping, would he recommend any course or any? Because I know there is some courses in which is done by Luca Regli, but
I didn't understand you, right?
Like any hands-on course, for aneurysm clipping.
Hands-on course.
Hands-on course. Hands-on course. Is that what you said?
Well, Raj, we have a course in December 7 to 9. So we'll be having a skull-based workshop, cadaver workshop. Other than that, I am with the WFNS anatomy, so I go to many places for cadaver courses. In December, we have one in Bangalore. So most of these courses, I demonstrate the skull-based approaches to these aneurysms, as well as if there are life surgery. In fact, in Gujarat, I'm going to be doing a few life surgeries. And plus there are many other places where we are invited for life surgeries. So either UHAS courses, like the Shaolin course, which is going on now in UHAS place, or any other courses with us or with the WFNS anatomy, you are most welcome. You can write to me and I can give you the details.
Okay, thank you very much.
Very good, thank you.
You're welcome.
Okay. Okay, more comments or questions from the panel? Okay, I thank you very much for your time. And Dr. Parthaban, thank you very much for your time. And we'll edit this and send it out to everybody. And we look forward to next week. Any idea what's you're gonna talk about next week, Hype?
Yeah, so we're doing another giant pituitary 2 days later, and maybe we can talk about the pituitary, if there's any aneurysms, or we have we have a brainstem exophytic, large brainstem exophytic tumor also for next week. I could give a talk about that as well. And let's see if there are any more good aneurysms. I can talk about that, but maybe I can tell you in a day or two as to how many cases that we can talk on by the next week.
Okay, very good. So we'll wrap this up formally and we'll stick around after. So thanks everybody.
Thank you. Bye.
Thank you guys. See you then. Thank you, Parthi. Thank you very much. Thank you all.
Okay, Hype, we're off the air. You can swear now. Hey, you know, this platform is made for the cross-fertilization of fields, like you mentioned, engineering and neurosurgery. You know, this platform allows people to communicate very easily from other areas of science or other than neurosurgery.
Absolutely. So we are actually connecting up with somebody from Switzerland who is a biomedical engineer. So we are really excited by these new projects of microscopes, the water knife. There's a water knife that I'm designing. So the water knife, the microscope, and the robotic drill assist, and many more things that we are designing. So I hope I am trying to get to understand engineering. Chisia is just starting off for biomedical. So she's also working hard. So let's see in the future that we can collaborate with many neurosurgeons. Actually, what we want, instead of engineers giving us something and say, okay, use this.
Right.
So,
yeah, because neurosurgeons don't have a chance to go into the engineering world too much. It would be nice if she could give a presentation on what you're doing sometime. Not.
Okay. Yeah, she says she can.
Yeah, that would be good for the educational, for the neurosurgery community to know what's going on. You know.
Yes, absolutely. So she will. She
Maybe
is a person
week.
of few words, but she is an excellent. She can teach you a lot, actually.
Okay,
so,
very good.
We will. Yes, for sure. We can ask her to give a presentation.
Okay, very good. Giovanni Sugini, you have an Italian associate, Andreas, here. I don't know do you know Giovanni Sugini?
Yes, yes, I know.
Giovanni, you there? Are you there, Giovanni?
Hello, John. Hello, Hype.
Hi, Giovanni.
Your camera's not working there, Giovanni. I don't know what's going on.
Yeah, I have a lot to duty and I'm working.
Oh, you're working. Okay.
Every weekend.
Okay.
I'm sorry.
No problem.
No problem.
Ciao, Giovanni.
I miss you.
Okay. Now, Dr. Kabulo and Nathalie, you guys are considering going to Nepal, correct?
Yeah, it's correct.
Of course.
Well, when are you going to Nepal now, Nathalie?
As I said, I wanted first to enter into a neurosurgery course, and then I'll program it the same year.
Okay. Very good. Very good. Mosindo, we haven't heard you. Mosindo, you there? To get a chance to introduce yourself and network with other people. Mosindo, no. Dr. Who? Anyone else we haven't met? There you go. Hi, Mosindo. How are you doing?
I am Mosindo. I am from Mozambique, resident of Neurosurgery.
Oh, excellent. Excellent. Thank you for coming.
Thank you too.
That's excellent. We had a lot, Dr. Gabula, we had a lot of African neurosurgeons here today.
Sure.
They're following you, Dr. Kabulo.
Sorry?
We have a lot of African neurosurgeons here today.
Sure.
Mozambique.
Yes.
He's a resident from Mozambique.
Yes, we were with him last time. He was on the panel last time.
Oh, okay. You met him.
Yes.
And Dr. Weil, he's from Sudan doing a residency, I think, in Saudi. Dr. Weil, are you in Saudi, Dr. Weil? Trying to unmute you there, Dr. Weil. Can you hear me, Dr. Weil? Hello, Dr. Weil. Okay, there you go. Okay, I guess we can't hold with Dr. Weil. Dr. Wu, Alpha, Akam, are you there? Is anyone there that hasn't been introduced? This is a chance to meet.
Yes, I am.
Network.
I am here. I am XM from Iraq, Baghdad. A final year resident in neurosurgeon.
Okay, I'm sorry. Are you Kevy?
Do you hear me, John?
I'm sorry. What's your name?
Yes, me.
Okay, yeah. Yeah, thank you for introducing yourself. Okay, you got it. Doctor Who, is Doctor Who there? Or Sagar, and Ibrahim, we met you. Okay, hi. How are you, sir?
It's very difficult.
Kevy, where are you from? Hi, Kevy, where are you from?
Yes, me, I'm from Cameroon.
Oh, okay, that's right. I'm sorry. Did we meet you before? I'm sorry, I may have
No,
introduced
this
you.
is the first time. This is my first time here in this platform.
Oh, okay, welcome. You're welcome to come to any presentation.
Thank you. Thank you.
Okay, anyone else? Hey, there's Dr. Who. Let me unmute you there. Hey, Dr. Hugh, how you doing? Sen Who?
Oh, hello.
Hello, how you doing?
I'm fine.
Welcome. Please introduce yourself to the panel because Sen is from China. He's a neurosurgeon working with Yuha, Herniziemi. Right? Are you there? Who?
Yes.
Yeah, could you please say a few words about yourself?
Myself.
Yeah. Where are you working? Where are you training, etc.?
Hello, everyone. I'm Husen. I come from China. I work in Henan Hospital, Henan Province Hospital, and I'm an assistant with Yuha.
Yeah, she works with Junio Herniziemi. I'm sure Dr. Parthaban knows the name. Yeah, Zen is going to do a conference next week, correct?
Yes.
Yeah, we're going to try to televise it if we can. And we can talk about that now, Zen, if you want. The conference is the 9th and the 10th?
9 to 11.
9 to 11. Well, we'll go over that. We'll go over that in a few minutes, okay?
Okay.
Okay, do you have some time? Okay. Lucinda. copy. Okay, and Dr. Parthaban, we're gonna edit that, Dr. Parthaban, and I'll send you the edited version.
Yep,
This is
definitely.
the one.
Yeah, definitely. Thank you, John. And
Yeah, thank you very much. We're getting some
thank you,
background.
John.
Okay, thank you, Dr. Parthaban. Well, someone's showing some video there. I don't know what it is. Because we're not being, this is not being recorded, but it's live on Facebook. Okay. Now, Dr. Who or Dr. Sen.
Yes.
Sen, do you do you know how to screen share with the Zoom? Do you know how to give a presentation?
I only know if the Professor Yuha and Professor Hugo catch their computer or cell phone, and then we can use Zoom to video their speech.
Okay, do you have a website for the conference next week? Do you have a website? Or does it have a poster or something? Do you have a website for the conference? Do you know? I think I may have the schedule. Did you send me the schedule, Sen?
Uh,
I don't know if I have the schedule. Do you have the schedule with you now?
Skype.
Can you show me? Can you show me the schedule? You going to screen share?
Yeah.
Oh, okay, very good. Yeah, we're going to try to televise this conference from China. Yeah, you know how to screen share, right? Can you show us the conference, Zen? Hello, Zen?
Yes.
Are you trying to screen share? Do you know how to screen share?
Screen share.
Okay, there you go, there you go. There you go. Okay, you know how to do it. There you go, okay. Yep. It's the conference, Abraham, that's going to go on in China next week at Yuha's hospital.
Actually,
you've heard of Yuha, right, Abraham?
Of course, of course.
Yeah, okay.
I talked to Yuha many times.
Oh, you're kidding?
Yeah, of course, in Istanbul, for instance, and actually because of Yuha, I went to Nepal to visit Ipe.
Oh, excellent. Yeah, I spent 3 months. I was with Ipe and Yuha for 3 months in Nepal.
That is why it would be cool. Zen, can we connect via WhatsApp maybe?
Me?
No,
I mean,
WeChat,
Oh,
Abraham.
WeChat. Yeah, sure. I think I have WeChat.
Yeah, let me give you you want Sen's address, right?
That'd be amazing.
Yeah, Sen, can you give Abraham is a medical student from Germany, and he wants to get Yuha's contact or your contact info.
Yeah.
So what is your contact info in WhatsApp in WeChat? What is the identification in WeChat?
WeChat or WhatsApp is both okay.
WhatsApp is also okay for you.
Yes.
Okay. Well, I can put my number here in the chat box.
Yeah, let's do that. Do that right now, okay? And I'll give it to Zen. Okay, let me give it. You see that number, Zen? I'm gonna give it to you in your WeChat, okay? Because I have a hotline to Zen's. That's the phone number. That's Abraham. Let me get. Okay, he's got your phone number, Abraham.
Okay.
Yeah,
right.
That's all you need, right? Is the phone number for for WeChat? Yeah, a lot of people use. Well, in China, of course, you gotta use WeChat.
Yeah, right. That is why I downloaded it. Actually, okay, you can, but yeah, I have WeChat. I just downloaded a few months ago.
Yeah. That's. Is Yuha in China now, Zen?
Yes.
Okay.
Because I heard he was uncertain on whether he will stay for another couple years or if he would quit working soon. I'm not sure. I think there was some uncertainty. Maybe Zen knows better.
I don't know. Do you know, Sen? Is Yuha going to stay in China?
After 3 years, maybe he want to stay in China, and after that he will go to Indonesia.
He will go to India?
Indonesia with his wife.
Oh, Indonesia. Oh, wow,
Indonesia.
Indonesia. Oh, yeah. Okay, yeah. With Fitri.
Yes.
Wife, I thought it was his girlfriend.
I already at your
oh, there you go, Abraham. There you go.
Yeah, that is me. Yes, right. That's my WhatsApp profile, right? Okay, cool. I'm Hussein. Yeah, nice. Thank you so much.
Yeah. So, Sen, do you have the schedule for the conference? Can you send it to me, please?
Yes, I have already sent it to you.
Yeah. I need. Okay, we want to televise it, right?
Yes, and
okay, we want. Can we practice? Can we practice? Can we practice? Can we practice doing it, or? Zen, can we practice doing it in the auditorium? Zen?
Yes.
Can we practice setting up the sound and the video in the auditorium?
The sound, the video.
Well, I need to practice to see if it works okay. Oh, there's the schedule. Okay, you sent me the schedule. I got that.
Most of the speech is Chinese. Only
I cannot open that. I can't open that file. Yeah, I'm going to give you my email address. Please send it to my email address, okay?
Okay.
Because I can't open it in WeChat. Where are you at Zen? Are you Zen? Are you home? Are you home or in the hospital?
My home.
Okay, that's Sunday night, right? So you eat American food in China? You eat hot dogs and hamburger?
Yes,
Yeah, you like hot dog?
I like hamburger and chicken.
Chicken. Oh, I love chicken. I love chicken. Hey, Amir, how you doing? Amir's from Iraq.
Hey.
Hi, is your
Hey, everyone.
hey, is your camera
Hi,
working
Amir.
there, Amir? We can't see your picture. There you go. There you go. For some
Hey,
reason.
everyone.
Hey, how you doing?
Yeah, I'm good. I'm fine. Thank you very much.
Yeah, you what year in medical school are you now?
No, I'm home. Now I'm at the home and
You're pre-med, pre-med, right?
yeah. Can you
Okay.
hear me?
Okay, welcome. We already had the presentation, but I'm trying to arrange a webcast with an Iranian neurosurgeon that's in the United States now. My nephew's dating his daughter. So I think I'll have a good chance of getting him.
That is how you network, Dr. John.
That's right. And hey, you use family. Why not use anything? But this is a great way to network online because, you know, the neurosurgeons, man, the residents, you can meet a lot of people. And look at you. You've met Yuha. How many med students can say that, really? But he must know it. Does he know your name and everything?
Well, I mean, we're in touch. Yes, he invited me over to China. That is why I was interested in talking to who.
Well, you know, I would highly suggest that if you can spend any time with Yuha, it's valuable.
Okay.
It's valuable. You know, he's an excellent teacher, and I'm sure he'd take you under his wing and make sure that you're.
Hello.
Yeah. Hi.
I think he's on the phone.
Oh, okay.
Hello.
I'm sorry. Yeah. So, yeah, you know, for me as an American, it's tough to get a visa. It's not easy.
Okay.
I tried to go there once, but couldn't get the visa in time.
Really? Yeah.
Yeah, and I tried. I didn't have enough time I wanted to go last month, but I didn't have enough time to apply. So someday I want to get there, Zen. Someday.
Yes.
Someday, who knows? But maybe if things get better between our countries, maybe I can go. But anyways, so Iran, China, Germany, Zimbabwe, Italy. That's great. That's great. That was a good session, right, Abraham? With IPE?
No, that was wonderful. That was wonderful.
Yeah, you know, like med students, you don't realize, man, when I was a med student, you never even get to speak to a neurosurgeon. They're too busy, and you know, this is a chance really to sit with a neurosurgeon and talk to him and ask questions, etc. So, yeah, we have Ibrahim. I would appreciate feedback on the app. We're working on the app still. We're fine tuning it.
Yeah, that was the beta version, I think.
It's still a beta. We're almost ready to release it, but I would appreciate you looking at it and tell me if there's any problems or there's any functionality, slowdowns or anything.
Yeah.
When you get a chance, because I think it's going to be groundbreaking.
Yeah,
there you go. Yeah. Like right now, we're on the app. Open the app. We're on the front page. This conversation right now that we're having is on the front page of the app.
Is it so? I thought we were not on air anymore.
No, we are on YouTube.
Oh, okay.
But I could shut it off, but we can. I can shut YouTube off too, of course. But on the app, it's on the first page. When you open the app, there it is, the live presentation on the first page of the app. And also open the app, you see that if you tap the video, you can also get the link to come in. So I think in the future, you'll be watching a webcast and you'll say, "Hey, I want to get in there. I want to comment on something," and you'll easily be able to enter.
Yeah.
To ask the question. Which everybody has a smartphone. Neurosurgeons are on the go. You know, I think maybe in the future there'll be more smartphone participation. Who knows where it's going to go? The technology's there, but I have a feeling that people will get more mobile, maybe access it from the iPad so the screen's bigger. But I don't think as many people will be accessing it from their desktop.
Right.
But you know, they're welcome to. But neurosurgeons are on the go.
Yeah, yeah.
And it's good they have the iPhone, and if they want to participate, they can participate. I'm even going to have a copyrighted where the app, the live presentation is on the app, the first page. So, because when you talk to investors, they want to know something that you have different that no one else can copy.
Yeah, I know that.
So how are things? So Zen works with Yuha. Hey, Zen, Abraham wants to come to China to be with Yuha.
That would be an idea. Yeah, I mean,
You're not sure, yeah.
It's always limited time, limited money as well, right?
Of course, yes. Of course. Okay, well, Zen is a go-to guy.
Mm-hmm.
So he helped set up. We had a webcast with Yuha. Zen helped set it up. Has Yuha got better internet, Zen, or the same?
It's sad to say, and it's the same.
Oh, okay. Okay. Well, when can we test the equipment for the auditorium, Zen? Do you know when we could test it to make sure the video and audio work good?
Maybe.
Okay, just let me know. Let me know by what WeChat. When you know a good time, let me know, okay? Okay? Okay, Sen?
Okay, I will let you know.
Yeah, just WeChat. Tell me a good time, okay?
Okay.
Okay. So, okay, gentlemen. Giovanni, you're quiet. Have you met Giovanni, Abraham?
No, we haven't met, but I know I've heard a lot about Giovanni.
Yeah,
Yes.
yeah, he's been here. He's been here. We gotta have you working for us, Abraham. You're pretty,
Yeah,
pretty
right?
active on this, man.
Well, I'm enjoying the Sunday nights always.
Yeah,
Sunday
that's right.
afternoon.
It's Sunday night in Germany, right?
Afternoon. It is still afternoon.
Oh, okay. Yeah, it's just morning
Yes,
in
it's so
Miami.
dark here.
It's morning in Miami. I think I may go down to the Keys today.
Oh, cool.
Oh, the
Nice.
Keys, a nice place. I really like it there. And it's only like an hour and a half from Miami. It's not far.
Maybe I should come over. I don't know.
Yeah, man. You're welcome. This place is awesome. When I came to live here, I knew I liked the beach and the sun, but I didn't know if I could stand the heat because here, major league hot. I mean, it's hot. It's not just warm. You sweat. You sweat when you walk like a half a block.
Mm-hmm.
When your body gets, it's not used to it. But once you're used to it, like now, no problem.
Okay.
When I first came here, wow. Latins like it here because Latins like the heat. They most of the countries there are pretty hot. So they don't mind the heat. That's why I think they like Miami. Plus the language, obviously.
Right.
Spanish is more Spanish here than English.
Oh wow. Okay.
Yeah, if you go somewhere, You better know Spanish, not English. English won't help you that much, but Spanish will. So, anyways, okay. How are things in Iran?
Good, John. Good. I still working to invite the neurosurgeons I know and to make a network with them. I sent email. I sent email last night, and yeah, that's the thing done. Can you hear me, John?
Yeah, I can hear you.
I'm quiet. Yeah. Yeah. Actually, last night you sent me the address of the neurosurgeons, the Hushang, Dr. Hushang Park, yeah?
Okay.
And I sent an email to him, yeah. Still waiting for his response.
Oh, okay. Well, let me know what the doctors say, okay?
Okay, actually. Yeah, sure.
Very good. Very good. Okay, Zen, I have to go. So you write me on WeChat, right?
Of course.
And then we meet to test the camera and the audio, okay?
Okay.
Okay, as soon as possible, okay?
Okay.
Very good. Okay, thanks everybody. And heading to the Keys.
Oh yeah, have fun. Enjoy.
Okay, thank you. Bye-bye, everybody. Bye. Thanks for coming, Zen. Thank you. Thank you,
welcome.
Amir. Thanks for coming. Kevin, thank you. And Giovanni, thank you.